First of all, I wish to thank you both for being here, for visiting us, and for this conversation that you're having with me. I'd like to start out with you and the question for you. Among clinicians, usually we hear people talking about borderline personality organization and borderline personality disorders. Sometimes or quite often using the terms in an interchangeable way. Can you explain us the difference, how you theorize that?
Borderline personality disorder is a specific constellation of pathological character traits or personality features, that's the same thing, that are clinically can be clinically diagnosed, constitute a specific type or category of personality disorder. That's borderline personality disorder. Borderline personality organization is a concept that we developed at our Personality Disorders Institute over the years. In fact, we started working with this, I would say, 30 years ago, discovering that various types of severe personality disorders had a common psychological structure, and that this common psychological structure determined both severity of their symptoms and typical symptoms that they all joined, although they had the different constellations had also different symptoms. So that borderline personality organization is a broader concept that includes all severe personality disorders, including the borderline personality disorder proper, and corresponds to a general classification of personality disorder into severe ones, borderline personality organization, and more moderate, less severe one, neurotic personality organization. The big difference between borderline personality organization and neurotic personality organization is in fact what we have called the syndrome of identity diffusion. The syndrome of identity diffusion is a severe distortion of the concept of the self and of the concept of significant others, so that patients with severe personality disorders have a fragmented, a split representation of the self and fragmented representations of significant others, which means that they have an enormous difficulty of assessing themselves in depth and assessing the personality of others beyond their immediate behavior. That's a common feature of all severe personality disorders. It has implications for diagnosis, prognosis, treatment. We developed that 30 years ago and have used it for our classification of personality disorder and the development of our treatment, transference-focused psychotherapy, geared specifically to severe personality disorders, including borderline personality disorder specifically. The official classification of personality disorders during those years, DSM-3 and then DSM-4, ignored these developments and stayed with purely categorical differentiation of the different personality disorders without considering the common features nor the degree of severity. It took them 30 years to discover what we had found and used in the development of our studies, and DSM-5 is now including as the basic concept that characterizes personality disorders, disorder of the self and of relations with significant others, and considers the severity of disorder of the self and the relation with significant others. So they have incorporated our concept with different names, if you want to, and without respecting sufficiently the underlying structure of identity. This explains, on the one hand, the difference between borderline personality disorder and borderline personality organization, and it also points to a central problem in contemporary psychiatry, which is a tendency toward a radical reductionism, a tendency to see psychological functions as a linear representation of specific brain functions, so that specific brain structure and functions and abnormalities in those structures that are genetically determined bring about psychological symptoms, period. That conception ignores that while psychological symptoms depend on a neurobiological basis, they tend to organize themselves according to internal dynamics at the psychological, the symbolic level, the experiential, intentional level, so that the radical reductionism consists in thinking that structures are neurobiological, everything else is epigenetic. You find the counterpoint to that in a radical reductionism within certain psychoanalytic traditions that treat psychodynamic symptoms as if they had nothing to do with the brain, which is the same thing in reverse. It is our view that to study psychology and psychopathology in a contemporary frame that does justice to the developments in our knowledge both about psychodynamics and neurobiology, to think about the interrelation between neurobiology and psychodynamics as interrelation between functions at the biological level that get organized in systems and determine psychological functions that in turn get organized as psychological systems that then may influence the neurobiological basis as well, so that there's an interaction between these two structural levels and, of course, external reality that influences both. So behind the issue of borderline personality disorder and personality organization lies a broad, implicit way of thinking that deals with the problem of the mind-body boundary.
Oh, thank you very much. I'm very grateful because you also anticipated me two related questions and you already answered. One was about DSM-5 and another one was about the fact that the work at PDI has been heavily influenced by your thinking, that your thinking is based on psychoanalytic theory. But in the last few years, you have produced a huge amount of research, very influential research on neurobiology. Frank, I have a question for you, and I'd like to ask you, what's unique in TFP, even in contrast to other models of treatment, even evidence-based treatments?
Well, that's a broad question. When you ask what's unique about TFP, we could think what's unique about it in relation to what you mentioned at the end of your question, the other evidence-based treatments for borderline personality. But we might also mention in what ways it might be different from a more classical psychoanalytic psychotherapy. Starting with the latter, we have there's a growing number of empirically based treatments for borderline personality, but the principal ones I think we could contrast TFP to and compare TFP to, since there's some overlap, are DBT, dialectical behavior therapy, mentalization-based therapy, MBT, and schema therapy, because those have been the ones most represented in the literature. And if you take TFP, contrasting the TFP to those as a group, I think TFP aims for deeper change. There's a level of personality change, what we call structural change, insofar as we're aiming for change of personality structure in terms of ego consolidation, a shift from identity diffusion to identity coherence, change from very primitive defense mechanisms which lead to a pretty maladaptive adjustment to life to a more successful adjustment to life. So in general, I think we're working at a deeper level of personality change. To be somewhat more specific, if we were to take dialectic behavioral therapy, it's based on the concept of borderline personality being primarily a disorder of emotional dysregulation, overreactivity, with which we have no objection that that's part of the picture. But I think what TFP adds is a focus on how the individual reads the meaning of an event, of an interaction, not just their overreaction to it. It gets back to what Dr. Kernberg said about internal representations of self and other. Our theory of the mind is that every individual has internalized representations that have to be adjusted to the subtlety and richness of the reality the individual is encountering. And borderline patients or persons tend to have rigid, stereotyped, and exaggerated representations that get triggered by an event, leading to an overreaction. So I would say, in contrast to DBT, we don't simply help the person tone down their reaction. We try to help them see how they read meaning in events, and in particular in interpersonal interactions, so their reading of their own self-state and of their ability to enter into a true empathy with the other person is enriched, and thereby the event might become more benign as they perceive it. Moving on to mentalization therapy, which also, like TFP, has to do with helping an individual read their internal states more accurately and also the internal states of another person more accurately. We feel that mentalization therapy and TFP are very similar at the start. The first phase of TFP is helping an individual understand symbolically and through verbal means internal self states they might have only felt in an inchoate way up until then, and also to gather a better representation of what's going on in the mind of the other. But then, more than MBT, we look at internal intrapsychic conflict, that because of the split self, there are states within the self that are in severe conflict with one another. And our job then becomes to help the individual look at the contrasting states that lead to the confusion and help integrate a coherent whole, which takes a step beyond mentalization therapy, which seems less to deal with intrapsychic conflict. I'm being very simplified in my answer. So moving on, to get to schema-focused therapy, superficially, people sometimes say that schema therapy looks like TFP because the schema or schemata involved in schema therapy involve a representation of self and a representation of other. But our reading of schema therapy is that it doesn't have the rich appreciation of unconscious processes, that since it's more rooted in cognitive psychology, the idea is that you can teach somebody the ways they see self and other without paying attention to why the person has difficulty and resistance to seeing what's going on. So we feel we appreciate much more unconscious resistance is once again going back to intrapsychic conflict. And another difference with schema therapy and with the other two is our emphasis on therapeutic neutrality, which is not an indifference on the part of the therapist, but not taking sides with any of the conflicts within the person. So while schema therapy focuses on what it calls partial reparenting, providing the patient with a, quote, good parenting experience with the assumption parenting experiences were bad, and the idea that someone can just learn through a new experience, we feel that distortions have to be analyzed and experienced as they are understood in order for there to be meaningful change. I've said quite a bit. Just to add about how we differ from more traditional psychodynamic or psychoanalytic psychotherapy, we've added a structure to the application of psychoanalytic principles. Psychoanalysis has a hugely rich repertoire of concepts and techniques, but often they're applied without as much of a method behind them. And one of the very important contributions from Dr. Kernberg and the group has been to provide therapists with a system of thinking of how to apply the techniques more systematically.
I think you answered perfectly to my question, and you gave us and all the Italian audience or the professionals working in Italy a very good hint or a very good stimulation in being clarified about differentiation. And I especially like your notes about giving a method to the psychoanalytic knowledge and psychoanalytic indications.